Hi, my name is Darwish, professor and consultant of obstetrics and gynecology. In this lecture, I'd like to share you my observation and postulation of a unique hysteroscopic finding of Darwish line during diagnostic hysteroscopy. I work in the field of endoscopy, particularly hysteroscopy, for more than 35 years, and my MD thesis in 1990 was on evaluation of therapeutic hysteroscopy, and we performed a lot of hysteroscopic surgeries. But I observed during tubal cannulations that we are inserting the cannula through the fallopian tube, and this is not just an opening, and I persisted to search on this point until the publication in the year 2021 on Darwish hysteroscopic triad, which represents part of the fallopian tube to be seen by hysteroscopy, which is triad of the ostium, intramural part, and the dark spot. Thereafter, we studied the physiologic change of this Darwish hysteroscopic triad. And 1 year later, after a long story of studying the fallopian tubes for many years, we published a study on what's called Darwish scope test, which is using combination of bubble flow test and peristalsis to ensure two of the three physiologic functions of the fallopian tube via hysteroscopy. During diagnostic hysteroscopy, we were used to comment on the endometrial cavity and cervical canal as regarding if you find any pathology or not, or abnormal vasculature. But during the work, I observed that the fundus of some women is irregular in some cases, and this irregularity is delicate and fine. And mostly it's between the tubal ostia or the Darwish triads, and sometimes extending few millimeters to the lateral pelvic walls. If the examination is done following menstruation or there is some bleeding, this defective part of the endometrial cavity is stained with blood. And you can see here, even if the endometrium is inflamed by endometritis, you can see this line as transverse line in the fundus, and it is not affected by the evidence of endometritis, which may signify that it is not covered by endometrium, because here is the endometrium inflamed, and this is pale without endometrium mostly, and this is endometrium. So certainly we observed this fundal effect in some cases, not in all cases of the hysteroscopic examination. If I think on the fundus of other organs like the gastroscopy, the stomach fundus, the cystoscopy, the bladder fundus, the eye fundus ophthalmoscopy, and the gallbladder fundus, we will not see any defective line in the fundus of these organs. And after that, we started to do combined hysteroscopy and laparoscopy for assessment of infertility women. And usually I start by laparoscopy and do hysteroscopy while the patient is awakened from anesthesia, as it takes just few minutes. So I performed hysteroscopy for thousands of women after laparoscopic approach. And this has been published in this review article by our team. Until we published a letter to the editor recently that the procedures that we should start during combined or concurrent laparoscopy and hysteroscopy should be laparoscopy. Why laparoscopy? Because it gives us an in-depth overview of the whole pelvis, identifies any associated lesion, and it has the advantage of real-time monitoring of hysteroscopic surgery, which includes trans-illumination test to predict perforation, protect vital organs by having assistant pushing them away from the uterus, and decreasing the danger of energy dispersion. In addition to the decreased risk of intravasation. And lastly, and importantly, which is the point of this talk, is the possibility of doing hysteroscopy after injection of the methylene blue to the endometrial cavity, which is called chromohysteroscopy. On the other hand, if we start by hysteroscopy, the hysteroscopy gives us clear view, of course, without methylene blue dye. The visualization is better, decreased pneumoperitoneum, decreased cardiorespiratory stress, decreased risk of air embolism, better access to the cervix in cases of high cervix after repeat cesarean section, which is tracted upwards. No endometrial damage by the cannula or the dilators, so proper visualization again, and it saves time by enabling identification of intrauterine lesions that could account for abnormal HCG. So now we have two categories of which one should be started with, laparoscopy or hysteroscopy. In the conclusion of this publication, we recommended starting by laparoscopy. But the question that I cannot see if I do hysteroscopy after laparoscopy because of the methylene blue dye. And this is actually a misconception. I'll explain to you this because methylene blue does not stain healthy epithelium, it stains pathologic epithelium. So the Darwish line is a delicate fundal transverse endometrial linear defect. Why defect? Because I showed you the epithelium of endometrites is not creeping on this transverse line, is not covering this transverse line. And that takes methylene blue, and the cells that the parts of the endometrial cavity that takes methylene blue are pathologic parts, either pathologic endometrium or defective endometrium or adhesions. Despite stain-free rest of the endometrium is completely normal, does not stain with the methylene blue, only this part, which is this transverse fundal linear defect. In some cases, not in all cases, during the hysteroscopy, and this is again a certain finding. I told you that doing hysteroscopy first is a misconception, as many doctors consider that methylene blue hinders proper visualization. We have to know that the normal endometrium is comprised of non-absorptive epithelium and does not absorb dye. The cells and their membranes have to be damaged to allow the dye to reach the cytoplasm and stain the nucleus. The endometrial staining may reveal endometrites, intrauterine adhesions, or other pathologies in addition to defective endometrium that should be biopsied. These are findings of previous studies. So hysteroscopists should get ready to learn about the advantages of endometrial cavity methylene blue staining during the diagnosis, particularly in cases of recurrent implantation failure, recurrent pregnancy loss, or infertility. And this is a concept of chromoendoscopy used by the GIT doctors and other specialties. You mentioned that it is endometrial defect. Why it is defect? I showed you that the epithelium is not covering it during the examination of patients with endometritis. How to prove? Probably it is not covered by epithelium. The proof by taking true cut sample from some patients, and we introduced true cut alongside the telescope to take the biopsy from the fundus. And we found by the histopathologic assessment that only myometrial tissue is seen without overlying endometrium. So it is an endometrial defect. So we observed this line without dye in some cases, with dye also, and it is not covered by endometrium. Another observation that the Darwish line was found in women who never given birth before, infertile women without any history of intrauterine surgery or hysteroscopy. This is a certain point. And this means that this line is not iatrogenic, is not related to any procedure done before, and this is certain. But why it is seen in patients who did not get any delivery or had no previous operation? Possibly it is signifying possible effective endometrial embryologic development. How does it occur? We have to go back to embryology. The Mullerian duct, which is just moving two tubes from lateral sides, formation, moving or migration and fusion and resorption, as we know. But the Mullerian duct, we have to know that it is covered by epithelium and mesenchyme. And after fusion in between 19 and 20 weeks of intrauterine life, there is resorption of the septum between the two Mullerian ducts of the uterus and cervix and upper part of the vagina in a regression way that may be codocephalic direction or bidirectional, as described by some authors. And the differentiation of the epithelium occurs in the intrauterine life, of course. At 14 weeks, there is a central cavity of the uterus. If we have a cut section of the uterus, central cavity covered by surface epithelium, which is inactive epithelium. Thereafter, at the 16 to 20th week of intrauterine life, there is elongated and branching glands in the endometrial cavity and cervical canal as well. So starting to differentiate of this simple epithelium to a functioning epithelium by glands in the cervical and uterine cavity between 16 and 20 weeks. At 20 weeks, the same is seen in the stroma with primitive endometrial glands and stroma. 7th month is completed development of the endometrium. After that, exhibit secretory change at 30 weeks, and third trimester showed progesterone action as well in this endometrium. So the development of endometrium is a little bit delayed after 14 weeks, starts to have glands at 20 weeks, and thereafter functioning endometrium at that time. But the embryology textbooks did not mention how the endometrium is covering the endometrial cavity. Is it coming? The cells come in a simultaneous way to cover the endometrial cavity like plants do from seeds, or in a cephalic direction or caudal direction, or in a circular pattern? Nobody knows. But if we correlate between the fundal delicate defects in the endometrium, this may suggest that the development of the endometrium comes in a cephalic way, starting from the cervix towards fundus, anteriorly, posteriorly, and laterally, and at the junctional point or meeting point, in some cases, there is defective fusion. So the hysteroscopic observation of this fundal line would provide a better understanding of the pattern of endometrial lining expansion in the intrauterine life, and opens the door for more embryologic research. And this is possible that the growth of the endometrium comes from the cervix to the fundus, as evidenced by these hysteroscopic observations. The Question is, we don't see it in all cases. Okay, do you see septum in all cases? This is a defective fusion in some cases, not in all cases, and this is junctional meeting point, as the septum is seen in some cases, not in all cases. And septum can be seen complete septum or incomplete, which means the caudal part of septum has been resorbed and the cephalic part is not. So the same applies for the endometrium, and this is another possible suggestion. So move forward to hysteroscopy. I told you we can see in this C photo the endometrium without staining. It shows fundal defect. With staining, with methylene blue, the defect is more evident, and sometimes with blood, it's evident as seen in D picture. And in these short movies, we can see the endometrium and this fundal defect with methylene blue dye taken by this defective endometrium or defective line, which signifying this defect of the fundus. Another picture of this case. When you go by hysteroscopy, after laparoscopy, you may find some bleeding and cervical canal due to the cannula and dilatation of cervix in some cases. But if you go inside the endometrial cavity, you can see the fundal defect, which is Darwish line in the fundus as seen between the tubal ostia and sometimes in the upper part of the lateral pelvic or lateral uterine wall. Here in this test of a negative bubble flow test, you can see methylene blue staining of this line of fundus, and of course fundus is extending to this part and takes the methylene blue dye due to defective endometrium. All these and other photos signifying that it is finding and observation should be considered. As I told you, some of doctors say we don't see it in all cases because we don't see septum in all cases, just insufficient endometrial cleaving in some instances, like the diagnosis of uterine septum in some but not all uteri. Others may say that we never see this description in hysteroscopic literature before. This is true because, number one, lack of knowledge. Number two, it is not seen in all cases. Number three, it is difficult to be seen unless you use chromohysteroscopy because it is a delicate line. Further, there is omission of methylene blue dye injection during hysteroscopy as the diagnostic tool, misconception of methylene blue compromising precise visualization. Perfect chromohysteroscopy actually requires waiting for a few minutes after methylene blue injection to have sufficient time to allow the dye to stain the nuclei of the injured cells. What is the possible effect of this observation? The proximity of this line to the implantation site in the upper and posterior wall of the mid-sagittal plane would cause insufficient fundal integrity and probably defective blood supply, and this should be studied particularly in cases with recurrent implantation failure or recurrent pregnancy loss or infertility. In conclusion, I would say that routine chromohysteroscopy at the end of laparoscopy for infertility and recurrent pregnancy loss is indicated to check endometrial integrity and pathologic lesions. The endometrial fundal transverse line that stains with methylene blue signifies unexplained defective endometrial integrity. The Darwish line may signify site of fusion of the endometrial cleaving to the line to line the endometrial cavity in the intrauterine life. This is an important observation. And lastly, its impact on fertility and the current pregnancy loss should be addressed in the future studies. Of course, I encourage all the interested hysteroscopists to start to focus on this point and to take biopsies and to discuss this issue with me anytime. The primary goal is to draw the hysteroscopist's attention to the need to perform chromohysteroscopy and observe a possible transverse fundal line whenever seen, and to determine the true prevalence, etiology, and clinical significance of this line. Of course, further research is needed. This work has been published in a recent journal in February 2024, as you see, and you can find it in the PubMed as well. And thank you for your attention.